Lab Baran, and myself, Dr. Bhageshri Hunkul, Professor, Department of Pathology, Jain Medical College, Belgaum. Our webinar hosts, Dr. Anita Bojes ma'am and Dr. Sumit Kujral sir. So these are a few of the reminders. Few disclaimers. Coming talks. So next lecture on 31st January, we have Understanding the Non-Neoplastic Endometrium by Dr. Anita Bojes ma'am. And on 2nd February, we have a CPC discussion by Dr. Arun, Dr. Ritambra Nada, and Dr. Arvind Sekhar from PGI Chandigarh. So let's start. I welcome Dr. Neha Mittal ma'am to share a screen and start.
Thank you. Good evening, everyone. And I welcome you all to this seminar on ovarian neoplasms. Can you see my screen, please?
Yes.
And can you hear me clearly?
Yes.
Thank you. Okay, so without wasting any more time, we will start with case 1. So a 48-year-old perimenopausal lady, P3L3, no family history of malignancy, no comorbidities, no addictions. She had a history of vague abdominal pain for 2 months. And she was found to have, on investigation, mildly enlarged ovaries, bilateral 5 into 6 centimeter on a pelvic ultrasound. Based on certain investigations that were done, she had to undergo a total abdominal hysterectomy and bilateral salpingo-oophorectomy. This is one of the first microphotographs from one of the sections from the ovary. Gunjita, can you describe?
Ma'am, section. Ma'am, can you hear me properly?
Yes, I can. Yes, I can.
Section shows normal ovarian stroma along with infiltration of ovary by tumor cells, which is arranged in cribriform microcystic pattern and also in nodules. And there are presence of numerous hyalinized, congested, variable sized blood vessels, and areas of luteinized ovarian stroma is also seen. And edematic ovarian stroma is also seen. And
one important thing when we are describing any section from the ovary, there is one important structure that we do not miss out on, and that is the capsule, right? The capsule, Hannah, you are able to see the capsule in this slide, right? So yeah, so what is your comment on the capsule?
It is partially encapsulated.
The ovarian capsule. The ovarian capsule, does it appear infiltrated or intact to you?
It is infiltrated.
But is it breached? Is it breached?
Yes, ma'am.
Is the capsule breached? Is the ovarian capsule breached? Do you see anything coming out of the capsule?
Breaching is seen. Ma'am, it is intact.
Yeah. So you can see the capsule, right? Ovarian capsule, right?
Yes.
It seems to have this vague nodularity. There are, nodules of, the capsule appears a little bit nodular, right? Irregular. But do you see anything coming out of the capsule?
No, ma'am, there's no breaching of the capsule.
No breach in the capsule, right? That is an important thing, right? When you're looking at any section in the ovary to talk about capsular breach. Okay, rest of it has been described. We go to the next slide. Anything more that you would like to say on this slide? So what do you think the lesion is? You think it is part of the normal ovarian parenchyma? It is a tumor? What do you think it is?
Ma'am, the ovarian parenchyma is infiltrated by a tumor, so very few foci of normal ovarian parenchyma is seen. The corpus albicans is seen, but
Right.
apart from that, we can see a microcystic pattern of cystic cribriform nodular pattern of infiltration of tumor cells. And
so you think it is neoplastic? It is disposed in nodules, right?
Yes,
and at this power has a very microcystic appearance, right?
Yes,
and the cysts seem to have some contents. Is that correct?
Yes, ma'am.
Okay, another high part, maybe Atul can chip in now. Atul?
Yes, ma'am. The tumor cells arranged in the diffuse sheet pattern, ma'am, they are showing intracytoplasmic clear vacuoles and peripherally displaced nucleus. So
there is no cytoplasm that is seen at this power, right? This is no cytoplasm. At this power, you cannot see the cytoplasm of individual cells. What you're seeing is a low power appearance, right? A 10x appearance,
yes,
right?
Sure.
Maybe I can go to the next slide and then.
Yes, yes, ma'am. The intracytoplasmic clear vacuoles are seen, which shows peripherally displaced nuclei. It also shows elongated cells with moderate eosinophilic cytoplasm and oval or typical nuclei.
Nabila, do you agree with Atul that these are intracytoplasmic vacuoles?
Yes, they are intracytoplasmic vacuoles.
All of these are intracytoplasmic vacuoles.
Most of them shows vacuolization in the cell, displacing the nuclei to the periphery. But many of the cells are scattered individually, present in the stroma, and these tumor cells are arranged singly in like Indian file pattern maybe. And majority of the cells show microcyst formation. There is also gland formation.
Yes, I think the predominantly many of these actually, if you see this is a large one, and don't you see this bluish boundary all around it, right? So most of these actually represent dilated glands with intraluminal secretions, right? Intraluminal secretions which are likely to be which are likely to be mucin, right? There are glands which are smaller in size, there are glands which are larger in size, and all these microcystic appearance are because of the dilatation of the glands and which are filled intracellular, which are filled within the gland with mucin, right? It is the infiltrative pattern of this tumor which is giving you the appearance of these being in an Indian file. Ovarian stroma is a tough stroma. When tumors go through that, they automatically appear as if they are in a cord-like pattern, right? But individually, if we see, then these are glands, right? These are glands with presence of intraluminal mucin. So what is the diagnosis here? Okay, Nabila, what do you think, or what do you want to do? Anything? What immunohistochemistry? How will you approach the diagnosis here?
Firstly, we'll most probably, I think it is a metastatic tumor that has come to the ovary somewhere from the primary site. Why
do you think that?
On gross.
Why do you think that?
Because there is presence of signet ring cell, and also the capsule is also intact, and the size of the adnexal mass, that is usually, it is around 5 centimeter. So in most metastatic tumors, it will be less than 13 centimeter. The capsule will be intact, and there is also presence of these signet ring cells.
Everyone agrees with Nabila, or somebody wants to go back to the history also in this case and give us important pointers from there. History and examination, which is the most important pointer here, which is helping us diagnose this as the entity that Nabila is pointing towards. What?
Bilateral involvement.
Exactly, right.
Bilateral involvement.
First and foremost important thing in such a case where you have an adenocarcinoma in the ovary with mucinous differentiation, the first and foremost thing in the history, you will go back and see whether it is unilateral or bilateral. Why? Why? Swati, do you have any idea why bilaterality is important? Gunjita, I come back to you. What is the importance of bilaterality?
Bilaterality primarily denotes mets.
So yes, you're likely you're correct in the sense that if it is a bilateral adenocarcinoma with mucinous differentiation, it is likely to be metastatic until proved otherwise. And if it is unilateral, it is the other way around. Okay, though unilateral can also be metastatic.
10% of the whole ovary is infiltrated by signet ring cells, and bilaterality. This all supports our Krukenberg tumor.
Excellent. I agree with those points. But as I said, first we start with the whether it's a unilateral or a bilateral mass. Okay, then you come down to the histology. It is a mucinous adenocarcinoma. As I said, the moment it is in a mucinous type of an adenocarcinoma, whether or not you have signet ring cells, it is not, signet ring cells do not make it metastatic. Okay, it is, the morphology is just a component. We have to take the clinical also into account in such cases. Then, as she said, the size of the ovaries, okay, which are not very enlarged. Otherwise, mucinous tumors are very large tumors. Bilaterality, then this kind of a microcystic appearance rather than a unicystic or a complex cystic appearance, right? Which is, and then we come down to the histology where you feel that most of these are glands, or some of them are even signet ring cells. And the growth of the ovary, yes, I forgot in between the growth. What would you expect the growth of the ovary in this case to be? Gunjita, you were referring to the growth findings in such cases. On growth, what will be the capsule? You just commented on the capsule on microscopy.
So the capsule is the capsule is intact. There's no breaching of the capsule, and
so capsule is usually intact in these cases. Nodular, intact, bossylated kind of a capsule, right? What else?
And ma'am, these are large tumors primarily.
As compared to mucinous tumors, no, these are not large. As compared to mucinous, they're usually smaller than usual mucinous tumors, right? But yes, the ovaries are enlarged, and you see a lot of preserved ovarian parenchyma, right? Which is unusual for usual mucinous tumors, right?
Yes, ma'am. Ma'am, it can present as fleshy, reniform, gelatinous on gross appearance.
Absolutely. So depending on the amount of mucin, yes, you will have the gross appearance, and these are all gross appearances that you can get in such cases. Excellent. Yes, so what next will we do to confirm, or what more information would you like to give the clinicians in this case?
And we would also like to know about the primary, if like the person has 2 months abdominal pain history. So we would also want to search for a primary, if at all some relevant history or information we get through for any gastric tumor or.
So what do you mean by searching? Would you go back? Would you ask your clinician to search? Is that what you mean? Or do you have the material right in front of you right now, and would you want to do something on it?
IHC panel. We can go for IHC panel. And for,
okay, I would want somebody else to tell me the IHC panel. So, Jabu.
Hi. Ma'am, can you hear me?
Yes, I can very clearly. Jabu, what would you like to do with immunohistochemical markers?
So for this case, we need to exclude whether this is coming from the GIT. So we can do cytokeratin 20, and also we can do cytokeratin 7.
Correct?
Yes.
That is all. So you will do cytokeratin 7 and cytokeratin 20?
Right.
That is it? That is all that you will do? Atul, do you agree with Jabu? Will that give you the answer?
No, ma'am. We'll have additional, we'll go for carcinomembranous antigen, and apart from that.
So you will add CEA, and how do you think that will help you?
Ma'am, if it comes positive, it will show that mucins, mucin mucinous carcinoma. It will come from the.
So this is a mucin producing tumor. What
Yes,
else
ma'am.
information will you get? You can see the mucin right on HNE. So how will the CEA help you in this case? As an immunohistochemical marker, how is it supposed to help you? Anybody else? Nabila? What is the most important thing? Sorry?
We'll go for IHC markers CK7, CK20, CDX2. That will be pointing more towards the colonic origin of the tumor.
Okay, excellent. So you will add CDX2, which will tell you whether or not it is a gastrointestinal primary, correct? Because looking at the histology, when you're looking at signatory cells, when you're this kind.
CA125 can rule out ovarian primary.
CA125 is a very non-specific marker. It can come in a lot of adenocarcinomas. Can you tell me something specific for ovary? Yes, we'll need to rule out. As I said, the most important differential is whether this is from the ovary or whether it's coming from somewhere else. So which is another marker which is better for ovarian or Mullerian primary? Apaxate, right? Apaxate, right? Apaxate, which is a transcription factor, which is very specific for a Mullerian primary. So that is what exactly my panel here would be, a CK7, cytokeratin CK7 and 20. Please remember, CK7 and 20 are both positive in ovarian primary mucinous carcinomas. So just positivity of these just doing these markers will not help you differentiate a primary coming from outside or a metastatic tumor vis-a-vis an ovarian primary. You will have to add a marker which is telling you the primary that you're thinking of, in this case a GI, so that will be CDX2. CDX2 is a pan-GI marker, and a Paxate which will tell you whether or not this is an ovarian primary. Paxate will be more important here than a CDX2 for me, because Paxate negativity definitely tells me that this is not an ovarian primary. Coupled with my history of being bilateral, coupled with the morphology of having these signaling cells, coupled with the size of the tumor which are not very large, then I can make this diagnosis that this is a metastatic tumor. Okay. Okay, so we go to see the IHC. So CK7, somebody quickly interpret CK7. Atul?
Yes, ma'am.
CK7 positive or negative?
Positive.
What type of staining?
Cytoplasm.
Nabila?
I'm negative. It is membranous stain, CK7.
So CK7 you are saying is negative?
No, it's positive.
CK7 is clearly positive in this case. You see, you see nicely membranous positivity in all, and now CK7 is highlighting the glandular pattern. Okay, can you see the glandular pattern? Okay, right. So CK7 is highlighting your glandular pattern in this case. Okay, CK20. I'm sorry for the quality of picture; it was very hazy in the scan picture. But CK20, just from far also you can see is quite brown. So CK20 was also diffusely positive. So as I said, CK7 and 20 both can be positive in both. So till now we do not know further. So this is your most important stain. Paxate, Gunjita, Paxate is positive or negative? Somebody else, Paxate, quickly please. Paxate.
Negative, ma'am.
Negative.
Yes, Paxate is negative. What type of staining is Paxate? It's a nuclear stain. Paxate is nuclear. You see the nuclei are not brown. So this is negative for Paxate. And SAT-B2, you see focal SAT-B2 positivity in the form of these brown nuclei, right? So SAT-B2 is another marker for lower GI or colonic origin. So what is your diagnosis in this case?
Kuchenberg, GI origin.
Okay, very good. Okay, that is right. And what will be the complete diagnosis? Krukenberg is fine, but the moment you say Krukenberg, Jaya will ask me Krukenberg from where?
Yes, ma'am.
So please give the complete diagnosis.
Kuchenberg tumor with mets from GI like.
From meds, when you have SAT-B2, you can suggest lower GI. Okay, if it was only CDX2, I would go with, GI primary. But CK7 and 20 is both positive. So you should know this, table. There is a beautiful table in every book of pathology where they've given what are the tumors which are both positive, what are the tumors which are both negative, right? But please remember, Gynac tract, this case was not only given for this, Krukenberg, but also given for the fact that if there is one, site in the body where you can be surprised by having dual pathologies, by having something more than what the eyes can easily see, then it is the Gynac pathology, this thing, DMG. So please be aware and please see your slides very, very carefully. And now back to the first picture that I sent you guys, and I've highlighted an area. Can you see it? It was there in the slide that was given to you. Can somebody tell me what this represents? A hyper view? Anyone? Describe, please.
Transitional urothelium.
Transitional urothelium in the ovary. So you kind of made your diagnosis. Can you give me something better? When you have transitional
Brenner.
epithelium,
Brenner.
yes, excellent, yes. So you see it's a very transitional looking epithelium, but there are these pseudocystic spaces. The cells can be cuboidal, and it was sitting there all this while, okay, in the slides that were given to you, okay, but the other tumor was so obvious and glaring that we kind of ignored this, okay. So this is a Brenner tumor, which is coexistent in this case with a Krukenberg or adenocarcinoma, mucin secreting adenocarcinoma of the ovary. Okay, so is this benign? In every epithelial tumor, mucinous tumors belong to the epithelial tumors of the ovary. So in every epithelial of the tumor of the ovary, you have to further categorize it into benign, borderline, and malignant. So what do you think it is?
Benign, ma'am.
Benign, ma'am.
So it's a benign because it doesn't have nuclear atypia. It is sitting in the stroma like any other Brenner's would. Okay, this tumor belongs here. This is its stroma. So here, this kind of presence in the stroma does not signify an invasive component in this tumor, right? It is more by cytological atypia and conversion to squamous. You know, more squamoid it looks, more malignant it will be. Okay, and more transitional, or it is like the more it looks, starts looking like a urothelial carcinoma. So this was a benign Brenner's tumor which is coexisting. Any importance of having this tumor here? A benign Brenner tumor, or is just a bystander? So if you missed it, it's okay. The patient anyway has a Krukenberg. So does this have an importance here? Anyone knows the association of mucinous tumors and Brenners in the ovary? So mucinous tumors, 10% of mucinous tumors can coexist with Brenner's tumors. Okay, and that can be all kinds of mucinous tumors. It can be mucinous ovarian, mucinous cystadenomas, borderline, or mucinous adenocarcinomas. And many a times when even you have adenocarcinomas coexisting with Brenner's tumor, they are part of teratomas. So if I had this as a unilateral case with a mucinous adenocarcinoma of the ovary with this kind of a histology, right, I would go back and sample more to look for areas of a teratoma, a malignant or a teratoma in which a somatic malignancy in the form of this adenocarcinoma may be arising. So combination of Brenner's tumor and a mucinous tumor, please go back to your specimens and look for a teratoma. So very quickly we'll go over mucinous tumors, which are epithelial tumors. There are many others and we'll talk about it. Brenner's tumors is another epithelial tumor. So mucinous cystadenoma and adenofibroma is the benign component. They usually have gastrointestinal and Mullerian type mucinous epithelium. The epithelium is non-stratified. Always remember, this will help you in identifying carcinomas which are simulating mucinous cystadenomas, which is a very common situation in ovary. So epithelium in mucinous tumors will be non-stratified if they are benign. So they can resemble any other epithelium, Mullerian, gastric, intestinal. And as I said, a component of dermoid cyst or Brenner tumor may be found. Please look for them, and if go back and look for in the specimen some more. Borderline, most common subtype in Asia. Multiple cyst, gastrointestinal type mucinous epithelium, variable degrees of stratification. So here the stratification, tufting, villous or slender filiform papillae, like you're seeing in the picture on the right-hand side, will start. If you have atypia, significant atypia in the lining epithelium, it warrants a diagnosis of intraepithelial carcinoma, especially if it is seen in a significant portion of the tumor. And there is a concept of microinvasion in borderline mucinous tumors, in which you see invasive component which is occupying less than 5 mm of the entire tumor. Okay, if the invasive component is identified but is less than 5 mm, that is the cutoff that is currently being agreed. There is a lot of controversy around this microinvasive term, but for all practical purposes, that is what you can remember. Invasion less than 5 mm with the same atypia as the borderline areas. Okay, so then you will label it as microinvasive. If the atypia in the invasive component is very high, even smaller amount of invasive tumor can be labeled as a microinvasive carcinoma. So mucinous carcinoma, as I said, there are two types: expansile confluent and infiltrative destructive. The expansile confluent pattern is more common. It simulates the borderline tumor and has to be distinguished from it by, look at the picture on the right top hand side. It is the complex intracystic proliferation. You saw the borderline. The borderline had proliferation within the cyst, but there was a lot of empty space within the cyst. A proliferation which is practically filling up the cyst without any spaces in between the cells is to be labeled as an expansile type of mucinous adenocarcinoma of the ovary, depending on the immunohistochemistry and the clinical, as I told you. An infiltrative pattern, look at the picture on the lower right side. It simulates what you saw in the slides that I gave you, but in this case, it was Pax8 positive, and this is a unilateral tumor, so we will think of ovarian primary in such a case. But if this is bilateral, first possibility will be a metastatic tumor. And this is another tumor which is considered in the differential diagnosis of a Krukenberg. Can anybody tell me? It is very commonly quoted in the literature, though the clinical presentation is very different. Can anybody tell me what this is? Again, those microcystic appearing cells. So this is a steroid cell tumor, which is a part of the sexcod-stromal group, right? This is a steroid cell tumor, and the moment you do a calretinine or a cytokeratin, you'll be able to distinguish. They will be definitely negative for EMA, which is an epithelial marker, and they'll be diffusely positive for calretinine, like seen in the picture here. Okay. So with that, we come to case 2. 25-year-old lady.
Shall I say,
Oh, sorry. Yeah, Jaya, please. Jaya and Santosh sir, please comment.
Yeah, I just sorry.
Yeah, I'll let Jaya madam comment.
Can you hear me?
Your voice is breaking.
Okay, I'll just switch off my video.
No,
Can you hear me?
We can hear
now
you.
it's better.
Yeah.
Now it's better.
Yeah. Okay. So I think, the challenge for us clinicians is to be able to come to this, have a clinical diagnosis before, the pathologists get to see it. And in this patient, there were just a couple of things, is that whenever a patient comes with lower abdominal pain and the ultrasound shows that, it is suggestive of a neoplastic ovarian neoplasm. I mean, today, the radiologist, had they been there, they would have told you, like the BIRADS, we have the ORADs. So, certain features on radiology which suspect it to be malignant. And then we would do tumor markers, which because she is 48, and whenever I have suspect an ovarian neoplasm, I think the first dictum in any ovarian neoplasm is to, even before the pathologist tells me what type it is to rule out, is it primary ovary, is it metastasis. So we would generally do a CA 125 CEA, and at times a CA 99. before even she undergoes surgery. And suppose in this case the CA is say 30 and the CA 125 is 500. Then if CA is raised, then and also as a part of staging we would do a contrast CT scan, a contrast CT of the abdomen and pelvis. The reason why all that is important is because if suppose it is a primary of the GI and we are able to have a suspicion of metastasis in the beginning, she does not need to undergo a surgery, because in a metastatic patient we may not undergo a surgery. So I think it is important to know and have a clinical suspicion. If the same patient had a diagnosis which was, if the same patient was 25 years of age, I think, which she has later, one would definitely want to do germ cell tumor markers. So bottom line, and not to forget, first and foremost is the history. I think whenever we are in doubt, and sometimes, all these IHC markers can be, not so strongly. She, of course, Neha showed you what was very classically present, but, sometimes the IHC markers may not be so classical. And when we have an overlap, I think the first and foremost for us clinicians is the clinical history and also clinical examination. And one of the areas we spoke a lot about GI, one of the areas where we also get metastasis from is the breast, and also like lobular carcinomas of the breast can also produce Krukenberg, and many times they come, and if you haven't done a breast examination, we may miss it. And similarly, gallbladder in India is another common cause of Krukenbergs. So, that is just, and whenever they tell us mucinous, we think 10 times before, and we, call up our pathologist 10 times and rule out any other primary before we take the diagnosis as a primary of the ovary. Yeah, thank you.
Thank you, Jay. Santosh sir?
I just want to add one point, Neha. The Paxate may not be very strong in these mucinous neoplasms of ovary,
Yeah.
and we really have to sometimes search for those few nuclei which are definitely positive, with which we would just suggest that this is primary ovarian neoplasm because Paxate is at least focally positive. So it is not those bright kind of positivity which you see in other primary ovarian tumors, epithelial tumors. So that's one point in Paxate, because that would change the whole scenario of being primary versus secondary. That's it. Thank you.
Right. So a very important point made by both Jaya ma'am and Santosh sir, that clinical is most important. This lady probably did not need the surgery. If the diagnosis was made pre-op, and this lady of course was worked up outside, was not worked up at our hospital, but this is the material that we got for review. So this is that is one situation, and then the other thing is Paxate, as sir said, diligently 15 minutes on 40x is minimum what you need with a good standardized Paxate antibody to look for the Paxate positivity that we expect to see in mucinous tumors of primary ovary. It is not like a low power Paxate positivity that you can make out in such cases, right? So this is a very important. These are both very important points. With that, we move to case 2. So 25 years, P2L2, secondary. This lady had secondary infertility. On investigation, had a large complex right ovarian cyst. She underwent laparoscopic right ovarian cystectomy plus endometrial biopsy. Right multiloculated large ovarian cyst was seen, 15 centimeters, punctured, and cystectomy was done. All this was done outside. What we received was material for review from the cystectomy, the slides and the blocks. Okay, so this is the low power view. Can somebody describe it, please? Swati, can you try?
Section shows multiple patterns of cells having some hemorrhagic area also noted, and cystic areas are separated by fibrovascular stroma. And that much I can appreciate.
So cells, okay. There is an area which appears more blue, right, on the left hand side,
Yes,
and the area which appears more pink or reddish, right, on the left hand side.
Yes, ma'am.
Vaishnavi, can you help Swati?
Ma'am, I think like tumors, left side there are tumor cells which are arranged in sheets, and in right side like large areas of hemorrhage is seen, and like this I think it is like necrosis in the right side.
I think that's necrosis. Jabu, can you help? Can you help her? Can you tell her what is there on the right hand side?
Yes, ma'am. On the right hand side, you see a hemorrhagic follicular cyst, which is like granulosa cells, and the central area looks like the tail area maybe it may be necrosis.
Right. So on the right hand side, what we see is a large hemorrhagic corpus luteum, right, which is a very normal finding in ovaries, right? A large hemorrhagic. There is no necrosis. This is all hemorrhage, okay, which is surrounded by. Okay, can anybody describe? Gunjita, can you describe a large hemorrhagic corpus luteum? What will you see? What are the layers? What is there in the center? What is it surrounded by?
Ma'am, I mean, an active, it has.
Atul? Okay, Nabila?
Ma'am, this hemorrhagic corpus luteal cyst consists of 2 layers. There is a theca layer,
Right.
that is theca layer, and there is a granulosa layer. The majority of the cells that we can see at this power are in the granulosa layer, and outside that there is a theca layer that is comprised of theca interna and theca externa.
Very good. Right. And on the left hand side, we can see this. And on the left hand side, what can you see, Nabila? What is there on the left hand side in this case?
The left hand side of the section shows diffuse infiltration of ovary by tumor cells that are mostly at this power. I can see only blue and some pink areas.
Excellent. Okay, Nabila, we continue with you. We go to we concentrate on the area with the tumor. So what would you like to say on this power?
At this magnification, at this power, I can appreciate firstly the capsule,
Right.
ovarian capsule, then the infiltration of this ovary by a diffuse pattern of tumor cells, and some pink areas, and maybe some small cystic spaces I can see on this magnification.
Okay, which can be just be retraction artifacts because of this being a very big section. But what you see is the capsule is intact, right? And this area is completely replacing the normal ovarian parenchyma. This is a very blue-looking tumor, which is not infiltrating. It is completely replacing the normal ovarian parenchyma. Okay, when we go to higher power, Nabila, continue.
Ma'am, I can't see the next slide. Okay.
Can you see it now?
This at this yes, ma'am. At this magnification, I can see most of the cells are blue with very scant cytoplasm, ill-defined cell boundaries, and multiple delicate vessels that can be appreciated in between these cells.
Even at this power, when we are talking about a 10x or a 20x, we first start with the architecture, right? So can you describe the architecture at this power?
The cells are mostly cells are scattered in a diffuse pattern in sheets.
Gunjita, do you agree with her? Are these sheets?
Ma'am, it is in a diffuse growth pattern.
Are these sheets?
Ma'am, maybe some nests.
Ma'am, these are in sheets.
They appear like
I've
interconnected.
marked areas. Would you call these sheets?
Ma'am, it can the microfollicular pattern.
So microfollicular, are there spaces in between? Do they have lumens? If you want to call it microfollicular, do you have lumens?
No.
So when something appears to be in a microfollicular pattern but loses the lumens, it is known as the
rosette.
It is known as the
Pseudo-
rosette is rosetting around something. No, this is a trabecular pattern. Okay, this is a trabecular pattern of growth, right? So these are trabecular patterns of growth. This tumor is in this power, at least in this field, at least appears to be present in a largely trabecular pattern with elongated cells, right? Lined by elongated cells. Any other thing that you would like to comment at this power, Gunjita? We are looking at tumors. So
intervening myxoid stroma is also seen.
Very little intervening stroma is there. Huh? We should not, there is no hardly, this is not the right field to comment on the stroma if at all we want to. But what we can say, do you see any necrosis? Do you see any necrosis in this field? You obviously don't see any necrosis. Appear pleomorphic? Do they appear? Do you see any giant cells? Any cells which look dangerous to you at this power?
No.
Small.
No. So that is what we call as a very monomorphic, right? The cells appear very monomorphic, bland, banal appearing cells. Correct? Everybody agrees?
Yes, ma'am.
Okay. This is high power. Atul.
Yes, ma'am. Ma'am, the nuclei are uniform, angulated with groove and grooved. You can see.
Yes, you can see beautiful grooves. Everybody could appreciate the grooves, right? Okay.
Yes,
so
and please identify this trabecular pattern, which is separated by this.
Yes,
okay, suggestive of
coffee bean appearance.
Coffee bean appearance. You have groove nuclei. Okay, yes, and a distinct paleness to the nuclei. A distinct paleness to the nuclei. Right? Do you understand that? A distinct paleness is there to the nuclei. Right? Many of the nuclei, they appear empty. Right? There are areas and areas in which the nuclei are appearing empty in appearance. Correct?
Yes, ma'am.
Okay. What else?
We are in this picture, we can also appreciate the call external bodies, ma'am.
Where? Can you tell the side where you can appreciate call external? Can you describe a call external quickly?
Usually these bodies are fluid punched out spaces between granulosa cells, and they are usually characteristic of granulosa cell tumors, ma'am.
Does everybody agree we are seeing call external bodies in this field?
And they are not evident in this field.
So there are no call external bodies in this field. Okay, there are no call external bodies. They are characteristic of the tumor that you're talking about, but there is another. There is a mark that I put in. There is an annotation which I put in the center of this thing. I'm showing it by. What is this? What is within this annotation?
Mitotic figures. Mitosis.
Yes, right. So this is something that you cannot, you cannot describe any tumor without talking about this. Whether there's any necrosis or not, and what is the mitotic activity, what is the mitotic count, right? All the tumors that we're talking about have grades. Okay, right. So you see some mitotic activity at least in this tumor, maybe one in this entire field, but maybe one at this lower corner also, right? Another mitotic field. So then this is not zero on mitosis. There are mitotic. Are these atypical mitoses or typical mitoses? So these are typical mitotic activities. There's a typical mitosis. Okay, so this is a tumor, as you said. This is having coffee bean-like appearance and grooved nuclei, trabecular architecture. You saw call external, but they are not there. But yes, and this is another area of the same tumor. Anything? Just shows the beautiful grooves. So what is your diagnosis?
Granulosa cell tumor.
Anything else?
These are the call external.
Call
bodies.
external.
These are the call external bodies, ma'am. Sorry.
So these are what you're describing as the call-external bodies. Okay. Because what you're saying are call-external bodies. This is what you're thinking is the call-external body.
Yes, ma'am.
Okay. What is in the center of a call-external body?
Eosinophilic material.
Eosinophilic material. What is that eosinophilic material actually?
Secretions.
Secretions by granulosa cells. Okay, so everybody thinks this is granulosa. There are types of granulosa. So can you qualify further? This was a 25-year-old woman. Anybody else with any other ideas? Please feel free to say.
It's an adult granulosa cell tumor.
So everybody thinks that this is an adult granulosa cell tumor. How will you confirm your diagnosis?
IHC markers, ma'am.
Okay, what IHC markers will you do, Atul?
Ma'am, we'll go for like, ma'am, FOXL2.
What category of tumors does this belong to? Sorry, 1 minute. Which category of tumors does granulosa belong to?
Six-cord stromal tumor.
Six-cord stromal tumor.
Out of that, again, out of that. Exactly, granulosa belongs to which category?
Pure.
Yes, pure sex cord.
Pure sex cord stromal tumor.
Pure sex cord tumor. Okay. Okay. So you will do, yes, Atul, you were telling us the immunohistochemical markers that you will do.
Yes, ma'am. FOXL2, ma'am, SF1
Excellent. FOXL2 is the most specific and sensitive for picking up an adult granulosa cell tumor. Unfortunately, we don't have it in our lab yet. So what else can we do?
Ma'am, we can go for calretinine, then SF1 inhibin A.
Calretinine will be positive or negative?
Positive, ma'am.
Okay. What else?
Ma'am, reticulin CD99, then low molecular weight cytokeratin and vimentin. We can go for these. All tumors will be positive, and negative tumors will be EMA and CK7.
Okay. Very important, very good. EMA and CK7 will always be negative in most sex cord and sex cord stromal tumors. And that is one very important differentiating factor from epithelial tumors. So it is the sex cord stromal tumors are almost always negative for EMA, and they are positive for various sex cord stromal like markers. For example, calret, inhibin. They may be positive for estrogen receptors. They are positive for FOXL2 like adult granulosa. On immunohistochemistry, adult granulosas will all be positive for FOXL2, but various other sex cord stromal tumors will also be positive for FOXL2 on immunohistochemistry. But at a molecular level, the exact mutation for FOXL2 will be seen only in adult granulosa. Okay, the mutation is specific for adult granulosa, but the immunohistochemistry is not. Okay, so in this case, your diagnosis was adult granulosa. Did you have any differentials? No. Okay, so let's start with the panel that Atul has told us. A few more pictures just to see if you want to change your mind or if there's any other thoughts that you're getting. So this is the calretinine. How do you interpret the calretinine here?
Weakly positive.
Calretinine is a, what type of staining do you expect?
Cytoplasmic.
Nuclear and cytoplasmic. Excellent. It will be both. And you neither see nuclear nor see cytoplasmic here. Right? So then this tumor is calretinine negative. And I can tell you that it was negative for CD99. It was negative for inhibin, and I don't have FOXL2. So any other thoughts? You were looking at ovarian tumors. This is a tumor which was present in a trabecular and a microfollicular pattern. You had nuclei which were grooved and clear. Any other thoughts? The first and the most important differential here was adult granulosa. Yes, you made that, diagnosis, but this is what happens to us almost every day, in pathology. We went ahead, did very confidently, I also did the same thing, calretinine, and it came dead negative, and so did others. So then I had to, rack my brain to understand, can any other thing, look like this? So anybody else has any other ideas? I gave you a lot of hints. There are people in the chat box who are putting carcinoid. No, this was synaptochromo negative. Well, somebody in the chat box has got it. Anybody?
Metastasis from papillary carcinoma thyroid.
Excellent possibility. But before I look at metastasis from papillary thyroid carcinoma, as I said, metastases are bilateral. Is there something in the ovary which can resemble papillary thyroid carcinoma? Do you know of something? What is it called? Jabu?
Stoma.
Yeah, stoma. It's called a stoma overi. Yeah, and you can have again all grades of stoma overi. Right? So again, because PTC, here you're faced with a differential. If you look at the nuclear features, yes, all of them fit with granulosa. But when I talk about follicular architecture, when I talk about microtrabeculae, when I talk about clearing, when I talk about nuclear grooves, all of them fit with papillary thyroid carcinoma as well. Excellent, Swati. So what all will you do to confirm your diagnosis, Swati, in this case, now that you made the diagnosis?
IHC markers.
Which markers? Come on, quickly. Anybody else will help? Vaishnavi. Okay, Jabu. If you think this is stoma, what will you do? TTF1 only? I think first we would start with an epithelial marker. I said epithelial marker is always negative in sex cord stromal. EMA is always negative. Not epithelial marker, EMA is always. So this is CK7, which is diffusely positive. Jabu, please keep interpreting the immunohistochemistry. What is this? This is Paxate,
Correctly.
which is, this is,
From
I think there's a lag.
869.
What is the Paxate?
It is positive.
It is diffusely positive nuclear staining. But as Jabu said, we need to do TTF1 in this case. So what is the TTF1?
Positive.
Diffusely positive nuclear as expected. But TTF1 can very rarely, but can come in very few of endometrial and ovarian tumors as well. So the diagnostic marker here we consider the most specific for thyroid origin tumors, for tumors which have thyroid histology, is thyroglobulin. Okay, so here you can see thyroglobulin is diffusely positive in this case. So what is the diagnosis here?
Stroma ovary.
Stroma ovary.
Again, you're not talking about the grade. You cannot just, I showed you mitosis, I showed you an architecture which is diffuse, trabecular, right? I showed you mitosis. So this is not just a benign, this is not a benign stroma ovari. This is actually a follicular variant of papillary thyroid carcinoma or a malignant stroma ovari, which is a follicular variant of papillary thyroid carcinoma, which is arising in a stroma ovari and very closely resembling a granulosa cell, adult granulosa cell tumor. Okay. WT1, another marker for sex called stromal, was negative. So, but I put this case to actually show you, the morphology, or just to discuss the sex called stromal here. So, as I said, the pure sex called tumors. This is a sex called stromal classification, and only the pure sex called tumors consist of adult granulosa, juvenile granulosa, Sertoli cell, and sex called tumor with annular tubules. And this is just for your ready reference. For Call Exner bodies, there is this eosinophilic stroma in between and not secretions. Okay, for Call Exner, there is stroma in between these and not secretions. You can have secretions in granulosa, but that is not forms a Call Exner body. Okay, so that is the difference between this tumor. That is why in the picture on the right hand above corner is our tumor that I gave you. You can see this is a clear eosinophilic secretion vis-a-vis stroma, which is present within the Call Exner of this granulosa cell tumor, which is on the right lower hand corner. And nearly all adult granulosa cell tumors harbor a recurrent somatic FOX2 missense mutation. All kinds of patterns are seen. And as Atul rightly mentioned, retic is one of the most important things because sex called stromal tumors again can have very overlapping. This is just one example in which, this is a rarer example in which a stroma ovari mimicked an adult granulosa, but a host of other sex called stromal tumors can mimic granulosa. And retic can be one of your important markers. Retic can be one of the more important special stains in which granulosa will be having reticulin staining around groups of tumor cells as highlighted in this picture. There are groups of tumor cells which are retic poor and the retic is in between in the stroma. Whereas other sex called stromal tumors which can have granulosa-like patterns like thecoma or other Sertoli latex cell type tumors will have pericellular reticulin. This is an example of a Sertoli latex cell tumor. You can see Sertoli form tubules again mimicking your follicles as we saw in this case. But on the right hand side corner, you see groups of latex cells in this tumor. And this is a Sertoli latex which again can have follicular pattern, can mimic granulosa, can mimic stroma. And the retic will be pericellular in these cases. These are some of the tumors which you see in the sex called stromal category which can have an overlapping histology. Very quickly now we go to the case 3. Before just Jaya ma'am and Santosh sir, any comments for case 2?
Yes, Neha, very nice case. I just want for the students, I just want to say that I think the differential diagnosis starts even before you see the slides. Like as a clinician, when a 26-year-old comes to me, the first and foremost differential diagnosis in my head is a germ cell tumor. Of course, next would be a granulosa cell tumor. Also, low-grade serous or borderline. So those are the differential diagnoses as a clinician that I would have in mind. And I would definitely do, tumor markers before we go ahead. And AFP, beta HCG, LDH, and if all that is negative, in inhibin B, if that is something that we strongly suspect. And also history, many of these sex-caused stromal tumors can come with, early menarche or, if they are Sertoli latex, come with virilization. So history and clinical examination give us a lot of clue as to what we would do. And if my pathologist tells me something which is not fitting into the clinical picture, we would definitely go back to them and, question this diagnosis. So I think it is, of course, this is a very rare scenario, the stroma ovari, this malignant, but of course, an important pitfall. But I think those are the things. And another very important thing is that, we should avoid, that is from the surgical aspect, of course, is avoid tumor ruptures in TROP because, something which is limited to the ovary can maybe in some situations be managed with surgery alone. Whereas once the cyst is ruptured, a lot of these patients would need adjuvant chemo, so a lot of emphasis on pre-op diagnosis and that is what. So again, I think as pathologists, before you look into the slides, I think, you see the age, what the history is and have some differential diagnosis before you move ahead. Yeah, that's it.
Yes, absolutely. I think those are pearls of wisdom, right? The clinical, in every case, we look at the clinical part before we, start looking at the case, right? So, before we look at the morphology, we first look at the, there are people who believe that the pathologist uses the phone more than a microscope. You keep calling, we keep troubling our clinicians when we have any queries. We want to know more about the clinical presentation of the patient, and I think that is a very important learning point here. Okay, the clinical picture has to fit with your morphology. Otherwise, go back, look for more, look for something else, think of more differentials, right? Now, case 3, very quickly, I have only 2 minutes to discuss this case. Or should I skip this case? Santosh sir, I can skip this case.
Then you can carry on, please. Carry on.
Neha, you can quickly do it, maybe in 2 minutes. Maybe you can
I'll
read
do it, sir.
read it yourself. Maybe yeah.
Yeah, sir, I'll do that. 55-year-old lady presenting with postmenopausal bleeding. On investigation, found to have endometrial thickness of 1.3 centimeter, which is very high, which is a very thick endometrium for this a lady of which is 55 years old. In this age, the thickness would just be around 2 or 3 millimeter, and an adnexal deposit which measured 2 into 1 centimeter. She had a THBSO done with the clinical impression of synchronous endometrial and adnexal primary. Endometrial section showed an endometrioid adenocarcinoma. I have not put those pictures for you to avoid confusion. FIGO grade 2, no LVI, less than half myometrial invasion. So to classify this lesion, to further stage this lesion, the adnexal lesion becomes very important. What is this adnexal lesion? So the pictures provided here are only from the adnexal mass for evaluation. So as you can see, this is the fallopian tube epithelium in this case, which is seen on the right upper side corner, and the rest of the area is showing this kind of a proliferation. Anybody very quickly, Gunjita?
Adenomatoid tumor.
Excellent, Riya. So this is an adenomatoid tumor, which is characterized by, in 2 lines, can you just tell me?
Adenomatoid tumor, the plica is, ma'am, the plica is lined by bland mesothelial cells, and the right side area, ma'am, it shows papillary growth-like structures, but these are probably...
This is the fallopian tube lining. Yeah, this is the normal fallopian tube lining.
And then the rest of the fallopian tube stroma is quite edematous, and few hyalinized blood vessels are also seen, and few cystic and microcystic spaces are also seen in low power view.
So low power view of this is, it is a characteristic very important, this thing to identify this on low power, microcystic characteristic, microcystic spaces, and proliferation of this stoma. Okay, all these appear to be vasculature, but this is not. These are not. All of these are not blood vessels, and this is a tumor of what origin?
Mesothelial.
Yes, this is a mesothelial origin tumor. So what all markers will you do to differentiate it from your carcinomas? So if you do a cytokeratin, A1, A3 are seen in this case, it will be confusing because these are both diffusely positive for keratins. Okay, A1, A3 is diffusely positive because mesothelium is diffusely positive for cytokeratin. The marker, the clincher here is calretinine, which will be diffusely positive in adenomatoid tumors and will be negative in most of your other endometrial ovarian type of cancers. Right. So in this case, the endometrium has the primary. Right. The endometrium has the primary, but the fallopian tube or the adnexal lesion is just a benign adenomatoid tumor. So this patient only has one primary here, which is the endometrioid adenocarcinoma. This is the most common situation. These tumors are usually seen in association with some other malignancies. The THBSO is done due to some other malignancy, but sometimes it may become a clinically important situation like this case. CD31, though it looks vascular and low power, is negative. So this is a benign neoplasm. Female genital tract is very rare and under-recognized, and misdiagnosis and infiltrative tumor may lead to disastrous consequences as far as the management is concerned. And now a clonal origin due to TRAF mutations has been detected, so it justifies the name adenomatoid tumor because it is clonal. Okay, thank you. With this, this is the last of my cases. Jaya ma'am, Santosh sir, any quick comment for this case?
Maybe you can stop sharing. Santosh can share.
Yeah, this can be very infiltrative. Yeah, we are seeing very infiltrative looking tumors. Let me see. Okay, is my slide seen?
Yes. Yeah.
Yeah, I'm getting double slides again.
But for us, it's fine.
I'm seeing double slides. Just a second.
You can go back, stop sharing, and share through the screen. Stop sharing.
Just a second.
You can go take your mouse cursor on the top. Yeah. Now share. When you share now, click on the share. Share the full screen.
Okay, again double screen is coming. Let me see. Now it's fine, I think.
Thank you.
Yeah. So
take your time. Santosh, take your time.
Yeah, just let me check my pen if it is working. I know my pen is not working.
Then I'll just make an announcement. Please don't send annotation. I was getting a lot of annotation requests and a lot of emojis while the presentation was happening. Please avoid doing that. It's a little disturbing for the presenter.
This is working.
Perfect.
It's fine. I think Neha's presentation has made things a little easier in the sense she has already spoken about the importance of taking sections of the capsule of the ovary. Am I audible properly?
Yes, sir.
Yeah, perfect.
Yeah, fine. So I think this is the general approach to any slide. When we see the slide is just a second. Just coming. There's some issues here. That's fine. Is it okay? Yeah. So before you put the slide onto the scope, it is always important to know the age, the site, the history, and the investigations. I think most pathologists make a diagnosis based on these things. Putting the slide becomes a secondary thing. Obviously, the morphology is important, but I think as we are all doctors first and clinician and physician first, these things become important. We have to look for any normal tissue around. We have to decide whether what we are seeing is a benign or malignant tumor. If it is a benign looking lesion, is it a benign tumor or inflammatory? If it is malignant, we have to ask questions. If it is a carcinoma, sarcoma, melanoma, lymphoma. And when it comes to ovary, there are other things like sex cord tumor. So those questions should come to your mind. Is it a germ cell tumor? So once you decide that this is malignant looking, these are the questions which come to your mind. If the morphology is characteristic, you can easily diagnose. You need not do IHCs. But in general, for a practice of oncopathology, in current area, you would need to do some ancillary techniques like immunohistochemistry, not only for diagnosis, but for predictive and prognostic markers. And if subtyping is needed, you need to do certain IHCs and molecular. So this is the general approach to any slide for the youngsters and for the students. So with that, we go to our cases. So in general, ovarian cancers, the most common ones are the epithelial tumors. Dr. Neha has already shown you the mucinous tumors. The lesser common ones are the germ cell and the sex cord tumors. The rest are really rare in the ovary. If you look at testes compared with the ovary, the testicular germ cell tumors form 95% of testicular tumors, but in the ovary, 80-90% of the tumors are basically epithelial tumors. Important for us as pathologists is to know the staging also. There is no need to mug up these staging. There is no need. It's readily available. If you are in doubt, please open this TNM staging and you can always stage your patients when you're looking at these slides. So that's some important. In brief, ovarian cancer staging, stage 1 is confined to the ovaries. Stage 2 is when the cancer cells have spread from the ovaries to other parts of the pelvis like the uterus and fallopian tubes. Stage 3 when it has gone to the abdomen, beyond the pelvis into the omentum, into the gut wall. And stage 4 when it has gone to the lungs and other distant areas. Grossing has already been spoken about a little bit, but you should know that when you're seeing an ovarian tumor, please describe it properly. Generally, many ovarian tumors are cystic, have a cystic component. If you continue to take sections from cystic areas, you will miss out on a lot of things. You should concentrate on the solid tumor component because that might be the area where more problematic areas might lie. And please take sections as far as possible from the capsule because that's part of the staging of the ovarian section. So that's important for the students to know. So case 1, we have a 26-year-old female. All 3 cases are young patients. And they are the problematic areas. If Jaya can always will agree with me, these are the patients who are unmarried or they are married, they don't have kids, they're infertile, and the clinical questions and the clinical decision becomes very important in these patients. So she had pain in abdomen for 2 months. On CT abdomen, there were large masses in both the right and left adnexa, and there were multiple subcentimeter lymph nodes in the retroperitoneum. There was loculated collection in the peritoneal surface. So this is the gross. Anybody wants to describe? Atul or Swati, want to describe this left ovary? What do you see, Atul?
So the left ovary shows a solid cystic variegated tumor.
Yes.
With areas of hemorrhage and congestion.
They're looking hemorrhage. They are very friable looking area, so that's an important clue. Friable looking area, solid cystic tumor, and the same is with the right ovary. This is the gross picture again, which you see. This is post fixation. You can see that there are cystic areas, hemorrhagic areas, maybe necrotic here and there, but they look a little friable. Mind you, such features can be seen in a variety of tumors. These are not characteristic, but in a young patient, 26-year-old, like Jaya madam had already said, you would think of certain things in a 26-year-old, like a germ cell tumor or mucinous neoplasm. Those things should be coming to mind. Now, even before we look at this gross, did I miss on something? Will anybody say what I missed out on? Clinically, Nabila, Gunjita, we want to add something? Before the surgery, things are done by the clinician, something which we miss out on a 26-year-old. Did I miss out on anything?
Tumor markers.
Tumor markers, very good. So you should know that when you are as pathologists looking at these tumors, you should ask for tumor markers. And in general, in a young patient, like Dr. Jay has already spoken about, we would do a serum CEA, AFP, beta HCG, and LDH. So in this patient, AFP was markedly raised. It was in the range of 15,000. Beta HCG was mildly raised. LDH was also raised. So does it tell you something even before you put your slide on the microscope if AFP, beta HCG, and LDH are raised? Jabu?
Yeah, it gives an idea of maybe germ cell tumors, you think of sarcomas, you think of tumors.
So it's important that the tumor markers are done in young patients, not even young, in all patients of ovarian cancer. They really help. And even before you put your slide on the microscope, if the AFP, beta HCG, and LDH are raised, you know that you're dealing with some kind of a germ cell tumor. So if AFP is raised to massive levels, you are definitely going to search for yolk sac areas because yolk sac are the tumors which secrete AFP. Generally, dysgerminomas will not secrete AFP. LDH is a non-specific marker, but again, any tumor which has high turnover can have LDH. So dysgerminoma and any mixed germ cell tumor can have high LDH. And beta HCG would be raised in? Nabila, you want to say beta HCG markedly raised in?
Choriocarcinoma.
Choriocarcinoma, very good. Yeah, choriocarcinoma. So markedly, but primary ovarian choriocarcinoma, that too bilateral, would be extremely rare. So this is a picture. Can quickly somebody describe this? Jabu, you want to have a go at this? This is the section from the ovarian tumor. So both ovarian tumors grossly look similar and microscopically also had similar features.
Photograph is showing the section from the ovary, composed of these cystically dilated structures, some with eosinophilic secretions.
Okay.
Some of the structures are, this is how they look like they're aligned by sort of an epithelium.
Yes,
and within the stroma is composed of single cells. The top corner is composed of adipocytes, and there's some variable areas of edema.
Okay. Maybe Gunjita, you want to take a crack at this? This is another section from the tumor. Gunjita, you want to describe what are these areas? What is this? Sorry, I'm unable to mark this. I don't know. This is not marking. So these areas, you have this? I think we have lost Gunjita. Is she there? Do you know what these areas are, Gunjita? Vaishnavi, you want to ask? You want to tell what is this at low power?
Cartilage.
Okay, this looks like a cartilage. What about these areas? They look more epithelial. Do you agree? Atul?
Yes, sir.
They look more epithelial. So, and then there are some glial looking areas, there are spindle areas, and then these are some blue looking areas. Even this low power, you want to think what this is? This could be, Atul? Teratoma. So this is definitely a germ cell tumor. So I told you that the serum tumor markers were increased. So we are definitely dealing with a germ cell tumor, and we have a teratomatous component in the form of cartilage, different kinds of epithelia. We had squamous epithelium, we had this mucinous epithelium, and we are having cartilage here. And then there are these areas, are more high power areas to show you. So this is definitely cartilage. Vaishnavi, you agree? These are cartilage areas.
Yes.
Nabila, you want to say something about this area?
This looks like a neuroepithelium, immature
Neuroepithelium. Very good. Why do you say so? Why do you say so?
Because at this power, these cells are very blue, very scant cytoplasm. Only nuclei can be appreciated.
Yes, yes. So they are not lymphocytes because they are aggregated. They look as if they are stratified and in groups. And then you have some pink material which almost looks like a what you call a pseudo rosette kind of pattern. You have see this, and they're very blue looking and very. Then there are certain areas which look a little more glial, and then there is some immature looking epithelium here in certain areas. You can see it here. You can find that these are the areas which you see. And then there were certain sections which completely showed these areas. Jabu, you want to speak on this? What is this area within this ovarian tumor?
This is a very solid area, sir.
Yeah.
In some of the parts, it has this occasional rosette-like structure.
Very good, very good. So you can see that there are some rosette-like formations. But how are these cells? They are looking very immature. They are looking very hyperchromatic. They are looking dark, and then they look stratified. They are multi-layered. So they look like immature neuroepithelium. Everybody agrees? See this? There is certain areas of kind of breakdown and these processes of these cells. So they look very, very something which reminds you of a neuroectoderm or a PNET kind of a picture. This is what a neuroepithelium looks like. They have these vague rosettes. They have these processes, and they look very blastemal-like appearance. So that's the importance of recognizing neuroepithelium. You see? So both these tumors in both right and left ovary had several of these areas. Some of more areas again to show these kind of immature neuroepithelium. Swati, did you appreciate the neuroepithelium in these slides?
Yes, sir.
You could make out. Okay, so they have these processes, and then they have vague rosettes, and that's important to recognize. So this picture I have shown you to show the cartilage. You can see this immature blastemal looking neuroepithelium, but then there are certain glandular like areas which also start looking like neuroepithelium. So it's important to understand that you have to have this kind of morphology, this kind of breakdown. You see these apoptotic cells in the center of these and some breakdown in the center of these islands. So that's important to note that many times you may get confused with certain epithelia which can start looking like immature neuroepithelium, but the classical neuroepithelium has rosettes. They're very blue blastemal appearing, and these have these apoptosis and central breakdown like areas, and that's how you recognize this neuroepithelium. Another area to again show and appreciate these homerite kind of rosettes which you have without true lumina, and that's how this immature neuroepithelium looks like. So everybody agrees that the patient had immature neuroepithelium?
Yes, sir.
Do you need any IHC to diagnose these? You see again the breakdown, neuroepithelium? Agreed? The central necrotic and this kind of apoptotic bodies in the center of these islands or towards the center of these stratified areas of these neuroepithelium. That is important to pick up this neuroepithelium or neuroectodermal elements. There are certain other areas in this tumor which look more bizarre and more bad looking cells in kind of wavy glandular pattern which were seen. Did you appreciate this? Nabila, did you see this? Can you describe this? These areas? I think we have lost Nabila. Atul, you want to tell how this area looks? Does it look like neuroepithelium, this one?
So glandular elements, cartilage.
Okay, so this is definitely cartilage. This looks glandular, but this doesn't have this blastemal kind of appearance of a neuroepithelium. You can see the neuroepithelium this side, very blastemal appearance, but this looks more glandular, but they are lined by more bad looking cells. Another low power to show cartilage and these kind of glandular areas. So you can see this more glandular looking areas, but they are not teratomatous. You see, they are looking very bad looking kind of glandular areas. You agree? They are very hyperchromatic, they look stratified, and then there is some kind of breakdown here. So these nuclei don't look very nice. So these are not neuroepithelium. You understand? These are not neuroepithelium. They are more columnar looking cells, more glandular rather than rosette cells. More areas from these tumors, you can see this appearance. These are more bad looking cells. Even at this power, you can appreciate the nucleoli. Can everybody appreciate nucleoli here?
Yes.
Indita, can you describe this area?
So my network is breaking, so I can not properly hear you.
Okay. Swati is there?
Sir, I can just read what you are saying, sir, but I'm not able to. The
Okay.
network is breaking a lot.
We can hear you properly actually. Yeah. Is Swati there?
Yes, sir.
Yeah, Swati, can you describe this area?
No, sir, I cannot touch.
You don't understand what this looks like?
No, sir.
Yeah, so this is what is a characteristic feature of embryonal carcinoma. So these you see these wavy kind of cells with bad looking nuclei and nucleoli. These are the embryonal cells. Okay, these are the embryonal carcinoma cells. And just close to them, you can see this more pink cells, more pink looking cells in a very loose kind of arrangement. They are the yolk sac cells. Okay, so in a germ cell tumor, many times you would see this arrangement of embryonal cells and yolk sac. They try to recapitulate the embryology of normal embryology, and you will find this embryonic carcinoma cells and the yolk sac tumor cells in close cohesion with each other. So you understand? So you can appreciate here again. You have this embryonal carcinoma cells like this, and just closely investing these is the embryonic the yolk sac tumor cells. You understand? Very loosely arranged. That's how they break. Did you appreciate? Atul, could you make out this embryonal and yolk sac arrangement? No, you couldn't. So this is a germ cell tumor which has got yolk sac elements, which has had two yolk sac elements because we know that the AFP was very high. So when you have AFP very high, you have to ardently look for yolk sac area. You understand? Because yolk sac is the tumor component which is going to secrete the AFP level. Fine? You agree? So these are the yolk sac elements, and this is the embryon. This is a very common arrangement which you see in mixed germ cell tumors or these kind of tumors. You see again higher power. These loose areas are the yolk sac elements, and this kind of arrangement of cells is of these tumor looking are the embryonal carcinoma cells. So they are like J and Viru, they almost always are seen together. In many of the cases, you will find this kind of arrangement of these tumor cells. So if you are in doubt, you can do a glypican, and the glypican will mark the yolk sac component. It will not mark the embryonal component in most of the cases. And then you can also do this is again a glypican to show the gyrating pattern of this yolk sac tumor, reticular kind of pattern. For embryonal carcinoma, you can have glandular pattern, solid pattern. The cells look really bad in embryonal carcinoma. They have apoptosis, they have mitosis, and that's how they look in under the mold. If you have doubt about the embryonal component, what are the IHCs which you will use? Nabila? Is Nabila here? I think Nabila also we have lost. She's speaking, but we can't hear her, I think. Ujjwal sir, I think half the people are not not here.
I'm here. I mean,
Swati
is there.
is there?
Swati is there.
Okay. I think Nabila and something Gunjit have problems in connection.
Vaishnavi is there.
So the IHC markers for embryonal carcinoma CD30 and OCT34. So in difficult cases, you have to do these IHCs to distill out these. This patient also had deposits in the omentum, and sometimes in these cases of mixed germ cell tumor or immature teratoma, or for that matter teratoma, you can have nice glial tissue in the peritoneum, which is known as gliomatosis peritoni. Now, generally, gliomatosis peritoni will not upstage the tumor to stage 3, and that is important to understand in germ cell tumors. So this was a bilateral mixed germ cell tumor with immature teratoma grade 3 and YSTN embryonal carcinoma. So what is the importance of picking up these things? You understand? Jaya, madam, you want to add something here? I think I'll quickly go.
Yes,
So these are the points. Yeah, please carry on.
Complete, then I'll say, huh?
Yeah, Dr. Jaya. Yeah. So these are germ cell tumors, and to distinguish the dysgerminoma from not dysgerminoma tumors, you may have to resort to certain immunohistochemistries. Very, very important is not to miss the capsule. I think Dr. Neha also mentioned this. Key capsular involvement is very important in ovarian cancer for the overall staging. If the immature teratoma is present, you have to grade the teratoma. So do you grade that? How do you grade the immature teratoma? It is based on the number of areas of immature neuroepithelium you see on any one slide. If there is less than one focus at 4x, you call it grade 1. If there are more than 3 foci in a 4x field, you call it a grade 2. So it's in any one slide. It's not like a different slide. In one slide, there are more than 3 foci at a 4x power, you call it a grade 3. It's a very dicey grading system, but then this is what is done and which is followed. It is a difficult to understand system, but yeah, this is what is the WHO is used. And this is important, mind you, because for grade 2, grade 3 immature teratoma, Dr. Jaya would definitely think of giving chemotherapy to these patients, even if the tumor is confined to the ovary. Agree, Dr. Jaya?
Yeah, so there is in grade 2 some thought of going away from giving chemo, but definitely in grade 3 one would consider chemotherapy.
That brings said to the importance how many sections you need to examine and how many sections need to be seen and how you pick up these foci and come to the grading of immature teratoma. So that's important. I think I'll quickly skip these because for the want of time. But you should know that the age group of mixed germ cell tumors and all these ovarian germ cell tumors is between 14 to 45. We generally see patients in the age group of 20 and early 30s of germ cell tumors. They generally present with non-specific symptoms of pelvic pain and menstrual disturbances, and investigations like ultrasound and MRI might help. Very, very important point which you should carry home is that serum tumor markers are extremely important for these patients, and most of the times the clinician already knows the diagnosis of germ cell tumor because of the raised AFP and beta HCG in these cases. I think I will skip this. And with surgery and combination chemotherapy, they have got excellent outcomes. The chemotherapy part maybe Dr. Jaya can highlight, and most of these patients do extremely well, especially in early stage cancers. The prognosis and outcome 5-year survival is more than 98%. Any questions? Any comments from Dr. Leena and Dr. Bhageshri? The problems and issues of immature teratoma grading?
So actually, yes, it's actually a learning experience for all of us, because every time to find out that immature component is really difficult.
Yeah, it is. And it does matter. The grading matters a lot because the patients are given chemotherapy based on completely on a pathology report. And anytime you give a report of grade 2, there would be questions from Dr. Jaya whether it is it's not grade 3 and whether she would want to give chemotherapy in those patients. Dr. Jaya?
Yeah, I think, thank you so much. I would just want to highlight some of the mimickers, and as you rightly pointed out that, germ cell tumors are such curative malignancies that, if we get the wrong report on the first time and we're given a wrong chemotherapy, something which is curative becomes palliative. I mean, just to want to state some 2-3 highlights, like we had a patient who had a so-called labeled clear cell carcinoma outside, in a 25-year-old. And I think where it was missed, and I think you would tell us that, clear cell carcinomas, yolk sac tumors can probably mimic clear cell carcinomas.
Exactly.
So if you see something like a clear cell carcinoma in a 25-year-old, even if the clinician has not done an AFP, please ask for alpha fetoprotein, beta HCG and LDH, and as was rightly pointed out, in anyone who is less than 40 years of age. Because the management will completely change from something which is a fertility sparing surgery to an outcome of 95%. If we are not able to hit it right the first time, the outcome changes completely for this patient. And somebody might lose their fertility or get chemo which is inappropriate. So so much so important is that. And just another highlight is like you have a high LDH, and that was another patient who was referred to as clear cell carcinoma. She had AFP beta HCG normal and LDH was almost like almost 5 to 6,000, and that was a patient which was actually Burkitt's lymphoma. I don't know how much Burkitt's clearing can mimic. So those are just some highlighters. And on the other way, also if you have very high tumor markers, they are diagnostic. But if you have AFP which is just like 5,000, beta HCG of 40 and LDH 200-300, then they may not always be diagnostic. And if your pathology is looking like an adenocarcinoma, occasionally we have had other cancers like GI malignancies we treated somebody thinking it is a germ cell, and we realized in upper GI endoscopy that it was upper GI cancers. So both tumor markers can and the pathologies can have great mimickers. So put everything together, and I think that's where talking to the pathologist helps a lot. Thank you.
Yeah. Thank you, Dr. Jha. Neha, you have any comments?
Also, just 2 points that what mimics neuroepithelium very closely. There are 2 things. I think one is odontogenic epithelium, which is a commoner situation, which has been alluded to in a publication from our center, which you are also a part of, and Dr. Kedar Deodhar is, I think, the corresponding.
So some of these-
Odontogenic epithelium, please look out for that. That mimics neuroepithelium, and sir has told very good points to differentiate the two. And a rarer situation is a cerebellar epithelium, a granular layer of the cerebellum when it is present in a teratoma. Then that can mimic a neuroepithelium, which is also a benign structure and should not be confused with this. That's it, sir. Thank you for that case, sir.
Yeah, I'll quickly move on to the case 2. It's again a young female, 26-year-old female, with history of abdominal pain for 3 months, and again she had bilateral adnexal masses. We did not have any other details. She underwent a laparotomy, and this is the cystic structure which was removed from her. And again, these are the gross pictures from this tumor. Who would want to describe it? Atul and Jabu, can you please describe? So this is a cut open ovary.
This is a cross picture of an ovary that has been cut open. You can see that it is multiloculated, has multiloculated cysts, also with some areas that are solid, and they are looking nodular.
So they're looking nodular and papillary. So there are some papillary looking excrescences within this multiloculated cystic kind of structure. We don't see any thick kind of mucinous material in this, but that would have, so it might have had some serous material which is drained out on cutting, but this areas can be very nicely seen. So this is the other ovary. You can see this. Atul, you want to describe this? Atul?
Is here, I think connectivity is poor.
Okay. Vaishnavi?
This is the cut section of the cyst, and it shows cut surface shows the papillary excrescence.
Yeah, it's throughout. It's like a carpet, but it's all papillary looking excrescence. You can see the thickened wall of the cyst here, and you can see probably that some of these papillary excrescences on the surface of the ovary also. Okay, we can make that out. Okay, fine.
Yes, sir.
So this is a low power micrograph of the sections from these ovarian tumor. Is Navila there?
Yes, sir.
Yeah, Navila, can you describe this at low power? What do you see?
This power shows.
You can see this wall of the cyst.
Yes,
okay.
The cyst lining that shows many papillary projections, and adjacent to this cyst lining, there is a presence of adipose tissue.
Okay, fine. This is from the other ovary, again, similar looking.
Yes.
A lot of papillary excrescences you can see at this power, and you can see the thick stalks as well as the thin stalks, and kind of branching pattern of these papillae you can make out at this power.
Yes.
At higher power, can you make out this, Navila?
Yes, sir. This power also shows the cyst lining and showing many papillary projections, and the branching of these papillary projection leading to other.
So you have some very thick stalks, then you have smaller stalks, and then you have even smaller stalks. So this is a hierarchical branching pattern, which is very characteristic of which tumor?
Borderline.
Borderline serous papillary tumor. So some more pictures to show that these kind of the tumor lining cells here, they look a little stratified, and then you can see the fibrous thick stalks of these this tumor, which is very nicely seen here. Again, more pictures to show you these thick stalks with the lining cells. Do the cells look bland, or they look very malignant? Are they very pleomorphic? Or maybe you are not able to make out at this power, Vaishnavi? Can you make out at this power where the cells are looking very bad, very pleomorphic?
Sir, like this some field shows like it is like pleomorphic.
Okay. Maybe we'll go to a little higher power. Do you see it more higher power? Atul, are you there? No, I think Atul has got connectivity issues. Jabu, do you think these are very pleomorphic looking cells?
At this power, they look relatively monomorphic, hyperchromatic with increased nucleocytoplasmic ratio.
Okay. But they have a pink cytoplasm. They have moderate amount of cytoplasm, but they look rather monomorphic. You can see that these lining cells, they look little serous in there. They don't contain any mucin at all. Here you can see that these are the stalks, which you can see here very nicely, and then you can see the branching pattern of these cells. Again, very thick looking stalks, stratified cells, which can be better out, more made out. So this is a high power. What do you think of the ATP and nuclear grade here? Dr. Jabu, Vaishnavi, Navila, anybody can take this question.
The cells show nuclear stratification at this power.
Okay. You can definitely appreciate the nuclear stratification. If you look at the cells, do they look very pleomorphic, or do they look monomorphic? Do they have nucleoli? Navila?
I can see the nucleoli here.
You can see the nucleoli. Jabu, Dr. Jabu?
It's variably there, sir, the nucleoli is there, but most of the cells not evident.
Yes. So the important point to note that most of these cells have nucleoli. At the first look, you will find that you will think that these are atypical and they are bad looking, but they are all similar looking. So they are very, very monomorphic. So they may have mild to moderate atypia, but there is generally never a severe atypia in these kind of tumor cells. You understand? So they look that they have nucleoli. At first look, you may feel that they are pleomorphic and they are bad looking, but they are generally very monomorphic appearing. They do not have those bad looking pleomorphic, multilobated and giant looking cells which you see in a high grade serous carcinoma. So that's the important point to note in these tumor cells. Again, a higher power to show that how they can be stratified. They can have nucleoli. They can look a little little vesicular, but they have this pink cytoplasm most of the times. They can have a little cilia at places, and that's how the high power of this will. So they can look a little atypical, but then they are never overtly severely atypical. They are never, those polylobated cells, those polyploid cells are generally not seen in borderline serous tumors. So that's important to understand. What is this we are seeing here? Nabila and Swati is there? Swati is there or Swati?
Yes, sir.
Yeah, Swati. What do you see this? What do you find here?
So multiple papillary-like structures separated by fibrovascular septa, and samoma body is also seen.
Yes. So do you think it is this high grade area? Samoma bodies, does it equate to high grade?
No, sir.
No, sir. No. So what? So this is important. So what we are seeing very slender looking papillae. You see, they are very thin looking micropapillae, which we are seeing. You see this? This is something like this. So this is a medusa head appearance in a borderline serous tumor of micropapillae. You see this? You see this head, and you see this picture. It's like the head, and this is like hair standing or serpents which are coming from the head. You agree? So these are very slender papillae or micropapillae which are coming directly from thick stalks. So this is what is known as the micropapillary areas in a borderline serous tumor. You agree?
Yes, sir.
Nabila, you have seen this previously? Have you seen micropapillary areas?
Yes, sir.
You have seen. Jabu, you agree with this? Dr. Jabu?
I agree.
Yeah. So these are what micropapillary appearance, and in borderline serous tumor, these are the most important feature you should be looking for. You understand? Because this is what actually prognosticates the patient most importantly. You understand? So this is what micropapillary area within a borderline serous tumor. So earlier we saw all these kind of areas which are thick stalks lined by stratified cells, but you don't see these very long slender papillae which are arising. You see this very long slender papillae? These are the micropapillary areas. More areas to show you these micropapillae. They can be totally floating in the lumen of the cyst. You may not even find that it is connected, but this should raise the possibility that there are micropapillary areas. Once you see this in focal areas, you have to go back to your specimen and you have to take more sections so that you actually try and quantify micropapillary areas in these tumors. See, more floating papillae, more slender looking papillae which are micropapillae which are arising from thick stalks. So they don't have a core of blood vessels. They are just lining of cells which are just emanating from these thick stalks in a medusa head like appearance. They can have a lot of microcalcifications, and you can have these floating papillae. So you should be aware that sammomatous calcification doesn't equate to a high grade serous cancer. And if you look at the immunohistochemistry, what does the immunohistochemistry in these tumors look like? The borderline serous and the low grade serous tumors. So they are serous, so they will come WT1 positive because that's a serous marker. Paxate will be positive. ER is generally very strongly positive, and Ki67 usually not done and not helpful, but in general it will not be very high. You agree to that? Is Gunjita there?
Yes.
Gunjita, you want to add something? So mind you again, ER can be positive even high grade serous cancers. So P53 is a very important marker.
So we can also do ERPR, CK7, and so T1 we've already done. And
so Gunjita, what are we trying to distinguish here? The important clinical question is we are trying to distinguish a low grade tumor from a high grade serous cancer. You understand? Because a high grade serous cancer is a chemosensitive cancer, whereas a low grade serous cancer or a borderline tumors are also low grade pathway. They are generally a surgically amenable tumor. You understand? They are not very chemosensitive tumor. So the most important marker to distinguish these two high grade and low grade is a P53. Why is P53 important? Swati, can you tell me? Swati, Atul, Nabila?
High grade tumors will have a wild type pattern.
Sorry, high grade tumors will have a
wild.
No, high grade serous tumors will have a mutation type pattern. So this is from a low grade tumor, and this is the wild type pattern. You see this? Some 20, 30, 40, 50% will be positive, some will be strong, some will be moderate, some will be very weak. But you will not have all the tumor nuclei which are strongly and diffusely positive. I'll show you one picture of a mutant P53 which comes in a high grade serous cancer. So in a low grade serous cancer and a borderline serous tumor, the P53 pattern will be wild type. So it will not be diffuse, it will be just scattered here and there, and in general it will be of moderate intensity. You understand that? Atul, are you there? Fine, Atul is not there. So this is how you interpret P53. It should be diffuse strong in more than 70-75% nuclei to be considered as mutant positive. A complete absence of P53 can also be considered as mutant, but that is called a null mutant pattern. You agree? Very, very rarely, less than 2-3% cases can show a diffuse cytoplasmic kind of P53, which is called as P53 cytoplasmic mutation pattern. And patchy nucleus, which we just saw here, is a wild type pattern which is seen in low grade serous and borderline serous tumors. Fine. You have to keep this in mind. This is extremely important, and in a given setting, this will make decide whether the patient needs extra chemotherapy or whether it's a completely surgically approachable tumor. You understand? Dr. Jaya, want to add something here?
Atul is here.
Atul is here? Yeah, let Jaya also add some points, sir.
Yeah, so I think what is most important, especially, is when you tell me that it is a borderline tumor. Do you have those Omental slides? If it is as long as it is confined.
I'm coming to that. I'm coming to that.
Okay. So yeah, in these borderline, it becomes very important whether it's borderline low grade or it is high grade, because that will make a huge difference in our management. So I think we keep pestering them for that. And the other very important pointer, especially the micropapillary pattern, is because if these young patients, somebody has had a cystectomy outside and that is a micropapillary, that is a harbinger of the fact that they have increased chances of local recurrence. So at least that unilateral salpingo-oophorectomy to go back and do that staging would be very important. Those are the
Yeah. So this is the slide to show that in borderline tumors, it is very important to sample the peritoneum and the omentum because they can have what is known as the implants. So once you have a serous borderline tumor, you are looking for implants of similar looking epithelium in the peritoneum as well as the omentum. and they are again designated as invasive versus non-invasive. So the non-invasive can be epithelial or desmoplastic with a lot of stromal response. So there are two types of non-invasive implants, and non-invasive implants basically tell you that the tumor is a has got a more protracted course of and it's got a good prognostic tumor. Once you have an invasive implant in the omentum and the peritoneum, then Dr. Jaya is going to label that patient, or we also have going to label the patient as a low-grade serous carcinoma. You understand? So even if the ovarian tumor is a very borderline tumor, if the implants in the omentum are destroying the underlying structures and look invasive, they should be labeled as a low-grade serous carcinoma. My slides are not moving. Then. You can see how these structures, so this is within the omentum, they are destroying the underlying structure of the fat and the adipose tissue of the omentum, and this is when you label an implant as a destructive or an invasive implant. So
where are they destroying? Sorry, can you show?
Yeah. So you can see that these planes of fat are completely destroyed, and there is a lot of stromal reaction to it, and the structures of this fat and the size of these fat globules are being destroyed. This is a very high power picture, Dr. Jaya. Generally, we pick up invasive implants on low power. It's a little difficult and dicey issue of picking up implants and calling them invasive versus non-invasive, and sometimes we leave the report as indeterminate kind of implants in certain cases. So this is a clarification. If you have a borderline serous tumor in the ovary and invasive implants in the peritoneum omentum, we call the tumor as a low-grade serous carcinoma. And there is no term like a borderline implant. The borderline is word used only for the ovary. And these are certain prognostic features which are important. Dr. Jay would like to comment on the excellent outcomes of stage 1 tumors.
Yes, so stage 1 borderline tumors has an excellent outcome, and they also can undergo a fertility sparing surgery because many of these occur in young women. But what is important is to kind of follow these patients up. And of course, borderline, a medical oncologist has no role. So even if it is stage 3 and non-invasive implants, there is no role of chemotherapy. So that's why, that importance where I think I'll answer the next question also is where, the most problematic thing comes is when you have a patient with stage 3 disease where there are implants and there are omental meds. So if Dr. Santosh tells me that these are non-invasive implants, I would just, we would just observe this patient. However, if these are invasive implants and it is a low-grade serous, then that would merit chemotherapy and hormonal therapy. So 6 months of treatment and additional hormone versus no treatment is a huge difference. And that's where, and it is also important, I think you would say that, to sample that adequately, because if you've missed out an invasive implant in a stage 3 patient, that would also be very detrimental, and the other way around as well. So that's it.
So this is just one slide to make you understand that sometimes if you don't have P53 and you are struggling on a small biopsy to call what is the problem between how to distinguish between a low grade and high grade, we look at certain features. Obviously, the high grade have moderate to marked nuclear ATPI. You have those polyploid cells. You have to try and count the mitosis. So in general, high grade serous cancers, the mitotic rate is said to be more than 12 per 10 hyperfields, whereas in low grade, in general, it is around 4 to 5 per 10 hyperfields. The necrosis in a small tissue may or may not be there, but I think the counting of mitosis and the nuclear ATPI and those presence of those very big polyploid looking cells is very important to distinguish. Obviously, P53 is very, very important. So this is a adnexal mass, again, a section taken from there. And if you look at it, the nuclear ATPI hyperchromasia is more pronounced. And when you do a P53, this is the mutant staining pattern. So Navila, you are there?
Yes, sir.
So this is the mutant staining pattern of P53. Almost 100% of the nuclei are very strongly positive, and that's when we call it a mutant pattern of P53. P50 abnormal pattern completely. This is what is known. So what we earlier saw was a wild type pattern which is seen in a low-grade serous cancer or a borderline serous cancer. Fine?
There is stromal invasion in the previous structure.
Which one? This one?
No, the previous one, where I think because between borderline and non-borderline, before what you call as invasive cancer.
Yeah. So I have not shown you pictures of low-grade serous cancer much. This is just a picture to show a focus of microinvasion in a borderline serous tumor, where you have these kind of papillae floating within the lacunar spaces. If you see, this is kind of the surface, and this is these are small foci of tumor cells which are infiltrating into the stroma with retraction artifacts. And those focus need to be picked up to call it microinvasive tumor. But in general, a microinvasion in a low-grade, in a borderline serous tumor does not change the prognosis, Jaya madam. So it is the micropapillary which is more important, which we saw that Medusa head kind of appearance, which we try to look for in a borderline serous tumor, because those are associated with presence of invasive implants in the peritoneum and omentum. So I just wanted to show the P53 mutant staining pattern, because somebody said that P53 is wild type in high-grade serous. P53 is mutant like this, or it may be completely absent. Navila, it may be totally absent also, and that's called a null pattern. But to call something null pattern, you should see some kind of faint staining in the stroma or the lymphocytes, and then only you can say that the tumor is a null pattern of mutant. Fine?
Okay.
Yeah. Gujal sir, I think you will end. It's almost 9 o'clock. We can stop here and we can take questions now.
Sure.
Yeah. Thank you so much.
You can stop sharing. Maybe.
Yeah, just a second. Sorry.
And I'll over to my colleagues, moderators, for the questions and answers.
Thank you, Dr. Santosh. Thank you, Dr. Neha. I think Dr. Neha is still there, because there are two questions in her section. First question is directed to Dr. Jaya Ghosh, actually. It is regarding, asked if there is a difference in the approach to treatment between follicular variant of papillary carcinoma in stroma ovary and the treatment of adult randosal tumor. Is there a difference in the approach to the treatment of these two tumors?
Yes, definitely. There is for those patients with adult granulosa cell tumors, if they are, if they're limited to the ovary, then surgery alone is sufficient. However, if they are outside the ovary and it's a granulosa cell, we do need to give them adjuvant chemotherapy stage 2 and beyond. And usually This is like a VEP regimen if they are young, or if they are older women, because bleomycin has lung toxicity, we use paclitaxel and carboplatin. Struma overi, I mean, if it is a benign one, of course, then it is observation alone. And if you have a follicular variant, I think that's a tricky situation where we also look at the thyroid in those situations. Yeah.
Okay, and now there's one question for Dr. Neha. She's asked, can you please explain Sertoli Leydig cell tumor?
I saw that question actually, and I didn't answer it. I think that is a very detailed discussion, and I think we need to have a separate session, on sex cord stromal tumors actually, to distinguish, to describe the different types and their morphologies. In general, this sex cord stromal, sex cord and Sertoli Leydig tumors are divided into three categories: well differentiated, moderate, and poorly differentiated, based on the differentiation of the Sertoliform tubules. From a very tubular architecture of the Sertoliform tubules and very little stroma to a situation where they become purely sarcomatoid. Presence of Leydig cells is important and must be looked for in each of these cases. And the sex cord stromal markers are common: calretinine, inhibin. All those are common, and WT1 are common to all these three categories. That is just a brief description, but yes, we need a detailed discussion of this. But
Just to add that, when you have a Sertoli Leydig, what is important as a clinician is, are you seeing heterologous elements in that, as Dr. Neha mentioned, because the presence of heterologous elements is an indicator for us, to give adjuvant treatment. So whenever you're diagnosing Sertoli Leydig, do let us know whether they are present or absent.
Thank you, Dr. Neha. Thank you, Dr. Jaya. And the next question is to Dr. Santosh. She asked, why is it embryonal component? Why not epithelial malignancy like adenocarcinoma and teratoma?
No. So to call something as adenocarcinoma, you have to have a frank adenocarcinoma. It typically looks like any, say, a colonic cancer or a gastric cancer or other adeno, and it has to overgrow the underlying tissue. In general, the cutoff is a 5 millimeter area. To call something as a somatic malignancy, that should be completely in a pattern which resembles a somatic malignancy. So supposing you have a squamous carcinoma of the buccal mucosa or squamous carcinoma cervix, the similar looking areas should be seen in a somatic, call it a somatic malignancy in a teratoma. Embryonal has got a very dirty looking appearance. They can have glandular pattern, solid pattern, they have nucleoli, they have apoptosis, mitosis, and in general, many a times embryonal is closely associated with those loose areas of yolk sac tumor, which is called like a polyembryoma pattern, which is called that's commonly seen. And if you have any doubt whether you're dealing with a adenocarcinoma versus embryonal, you can do a CD30 and OCT4, which will help you pick up these differences.
Now again, it's related to the second case. Do we include invasive implants in the staging of low-grade serous carcinoma?
So once you call, so the concept of borderline, I knew this, all these questions and confusion will come in borderline. So let me make it very clear. Once you have taken multiple sections of the ovarian tumor and you have called it a borderline serous tumor, then only you use the word implants for the peritoneum. Once you have labeled the primary ovarian tumor as a low-grade serous carcinoma, you have C invasion and it's a frankly invasive low-grade serous carcinoma, P53, which is wild type there, then whatever there is in the omentum and peritoneum becomes a metastasis, because you are already labeled the primary as a carcinoma. So everything in the omentum and the peritoneum becomes a metastasis. The implant word now is only used for borderline serous tumors only. So in fact, people don't even want to use the word the invasive implants. You understand? Their implants are basically epithelial and desmoplastic, non-invasive kind of implants. Once you have invasion, not to add confusion, just call the patient as a low-grade serous carcinoma.
Okay, the next question is, how to differentiate between borderline ovarian and low-grade serous carcinoma?
Borderline and low-grade serous. So once you have to look for invasion. Like I showed micro-invasion. So for micro-invasion, like Dr. Neha also said, in my mucinous tumors, you have a cutoff of 5 millimeter area. If you see multiple sections, you see a area of 5 millimeter, which is looking similar to the overlying epithelium. You call it a micro-invasion. If it looks a little dissimilar and something which is very, very back-to-back and completely looking a little more different than the overlying serous area, then you probably call it a low-grade serous carcinoma, even if it is less than 5 millimeter. These are very, very dicey situations, very rare situations, and I would not struggle to find micro-invasion in a borderline serous tumor until there are. So the more important point in borderline serous tumor is to look for micropapillary areas, because those are the ones which are included, and those are the ones which are sort of associated with the presence of peritoneal disease and the invasive disease.
I think you've already answered this question. Can there be invasive implants in low-grade serous carcinoma?
We already answered that question.
So now the next question comes as, how to differentiate between, what is the role of P16 in low-grade serous carcinoma?
P16, like you said, P16 is positive in high-grade serous cancers, and it is not HPV, so it is not a surrogate marker for HPV. In cervix, we use P16 as a surrogate marker for HPV infection, but P16 we should know is a part of a cell cycle marker. It is associated with the RB protein pathway in the cell cycle, and P16 may be expressed in high-grade serous cancers, but not generally in low-grade serous cancers. So P15 and P16 can sometimes help, and we sometimes do use in combination to call something as a high-grade serous. These problematic cases come on biopsies rather than resection. Resection, generally we take multiple sections, and we are pretty confident of distinguishing low-grade from a high-grade serous cancer.
Okay. Can we differentiate between, the next question is, can we differentiate between micro-invasive low-grade serous carcinoma and serous borderline micro-invasive low-grade serous carcinoma?
Oh my God, I can't even understand the question. So I think I've already answered the same thing. This is the same 5 millimeter cutoff, and if the invasive area looks similar to the overlying epithelium, we still maintain that it's a micro-invasion in a borderline serous tumor. But if it is looking a little different and more confident but more destructive, even if it is less than 5, we would call it a low-grade micro-invasive carcinoma.
So next is to Dr. Neha, I suppose. Which important IC markers can be used to differentiate between adult granulosa cell tumor and malignant Brenner by transitional cell carcinoma?
So it is no IHC marker that, granulosa and Brenner, you're saying? Granulosa and Brenner, no?
Malignant Brenner.
Yeah, so there are hardly any markers which are overlapping between the two, right? So granulosa will be negative for epithelial markers, whereas Brenner's will be positive for epithelial markers, right? EMA will be positive in Brenner's as compared to negative in granulosa. And from there on, you can take it. I mean, the transitional epithelium or uroepithelial markers will all be positive in Brenner's, which include P63 and GATA3, right? Which will all be negative in granulosa cell tumors, which has its own battery of IHCs, which is more on the second-stromal lines like Calret, Inhibin, MYC2, CD99, and definitely the IHC, the specific IHC marker would be FOXL2 if you have that available for granulosa. And for transitional epithelium like Brenner's, it will be epithelial markers and GATA3 and P63.
Next question to Dr. Jaya. Is there a treatment difference in yolk sac with embryonic carcinoma versus high-grade mature teratoma?
Yes, so one is that if it is this, I don't think there's anything as a high-grade mature teratoma. So once you say that it is a mature teratoma, it's mature. So there is no question of it being high-grade. So if I have a mature teratoma and it is confined to the ovary, there is no need for adjuvant chemotherapy. Just a word of caution where if you have mature teratoma on the pathology, suppose you get some outside slides for pathology and you find mature teratoma, but you look at the history that that AFP is high or beta HCG is high or LDH is high, then I definitely know that irrespective of what the pathologist tells me that there is an immature component to this element. So if you haven't found immature, then go ahead and look at it. So when I say a mature teratoma, I look at not only the pathology but I also look at the tumor pre-op tumor markers. So if pre-op tumor markers are normal and the pathologist tells me that it is a mature teratoma, the treatment is observation, and of course we follow these patients up 3 to 4 monthly. However, if my tumor markers are high or the pathologist tells me that there's a yolk sac or an embryonal carcinoma, even if it is 1A, that generally merits adjuvant chemotherapy for these patients, which is generally 3 to 4 cycles depending on the stage of BEP, that is bleomycin, etoposide, and cisplatin.
Yeah, so I think important thing is if the markers are not very highly raised, the AFP say 200, 250, and we are finding predominantly teratoma. But Jaya would really probe us for that to try and find a yolk sac component in that, because generally a mature teratoma, pure mature teratoma should not be secreting any AFP. So the problem areas come when the markers are not very highly raised. If it is very highly raised in 10,000, 15,000, we know that there is yolk sac and there is going to be yolk sac in your sections. The problem comes in those very low kind of, but generally in ovary that's not an issue. That comes more of a problem in a testicular germ cell tumors rather than that. Yeah.
And there's one more question for Dr. Jaya. Is there a difference in management of low-grade serous carcinoma and borderline serous carcinoma?
So borderline tumors are not cancer. So that's what I say, that even if it is a stage 3 borderline, there is no role of a medical oncologist. So I'm out of the picture. And so basically management of a borderline tumor is surgical. So even in advanced borderline tumors, even if it is a stage 3 borderline tumor, which means that the omentum, even if it has disease, is non-invasive implants, the treatment will be surgery and followed by observation. Whereas if the same patient has a low-grade serous carcinoma or these borderline with invasive implants, which would make it low-grade serous, if it is confined to the ovary, if your low grade is confined to the ovary, so if I have a 1A low grade tumor, then it is observation, but 1C is a little debatable. But otherwise, if it is a 1C or stage 2 and above, then of course we do need adjuvant chemotherapy for these patients. And in advanced low grade, after adjuvant chemotherapy, because these are also hormone positive, one does also put them on hormonal maintenance as we do in breast cancers.
Okay, thank you. Next is to Dr. Santosh. Is borderline, in borderline serous tumor, can peritoneal fluid come positive?
Yes, it can definitely. So if you have a lot of peritoneal deposits,
okay.
In fluid, you can definitely not call it invasive versus non-invasive. We struggle to give invasive versus
non-invasive implants which give the positivity in the peritoneal fluid?
Yes. Okay. Invasive and non-invasive. Any kind of implants in the peritoneum can give rise to positive.
Yes, and the common problem which occurs is, if the fluid is seen in isolation, fluid might be called as an adenocarcinoma, and then you would be labeled it. So if I get a fluid as an adenocarcinoma and the tumor says borderline, then I go back to the pathologist and ask them, please look at the two together and tell us, should I treat it with chemo or just observe it? Yeah.
Okay, but then it will require a biopsy, right, to confirm?
No, meaning this happens like if fluid has gone somewhere else and tumor has gone somewhere else, so that is the problem. But if the same pathologist is looking at the fluid
in the presence of any atypical cells in fluid, we would tend to call a fluid as metastatic adenocarcinoma. That's the general terminology which is used. But when we see in concert with the histopathology, which is like a borderline tumor, or then we would go back to the fluid and say probably these are from the implants which are present there in the fluid.
I think that comes to an end of the questions. So one more question: what is the most common type of mixed germ cell tumor, and what is its clinical significance?
So I think you must not carry home the message that mixed germ cell tumors are very common in the ovary. The commonest germ cell tumor in the ovary is again teratoma and dysgerminoma. These are the two common tumors which we see. If you look at mixed germ cell tumors, the combination of teratoma with embryonal carcinoma, again embryonal carcinoma is not very common. So whenever you have embryonal, you'll always have a combination with generally a yolk sac tumor in the ovary. So what I showed was a very, very unusual case of a bilateral mixed germ cell tumor, and this was unusual, and it had all the histology. So it had all the different types of teratomatous epithelium. It had the embryonal component and the yolk sac and the immature component, which is not a very common finding in ovarian cancers.
Yeah, I just wanted to add that, even in advanced germ cell tumors, even if you have a stage 3 or a stage 4 germ cell tumor, it is possible to give chemo and do a fertility sparing surgery, which is not like, any other cancer. So it's so important to make that diagnosis of a germ cell tumor because, if I have a stage 4 germ cell tumor, she can still have fertility sparing surgery and, a long-term outcome of 60 to 70% based on the, histological subtype. So that's very important. And, that's it. And of course, bilaterality, once we think as clinicians, is, they have a history of primary amenorrhea, and we know that they might be having dysgenetic gonads. I mean, we do the karyotyping before they undergo surgery, and that's where a common situation for them to undergo a bilateral surgery.
that brings into the questions. So thank you, Dr. Jaya, for this for explaining the clinical side of all these tumors and the implications. So thank Dr. Santosh and Dr. Neha for this informative discussion and these interesting slides. And
Thank you all students. Thank you, Pooja, for